So another topic that is attached to orthognathic surgery and cleft lip palate is distraction osteogenesis for the cleft lip and palate patient or for normal orthognathic patients. So what do you understand by distraction osteogenesis? Basically, distraction osteogenesis of distraction is something you are moving apart. Okay. So if there is a bone, you fracture the bone. In orthognathic surgery, you take the bone down and plate it. But if you want more advancement, then there is a limitation in orthognathic surgery also, that if your pedicle is moved more apart or more distance is there, then there is a blood supply will break and there is no bone formation. So in distraction, a small fracture is there. Yes, bone formation is there. Then this is slowly set apart. Okay, slowly set apart with the help of intraoral or extraoral distractors. Okay, so we'll start with the maxillary hypoplasia. The consideration is aesthetics and occlusion. Deformity is transverse, vertical, and horizontal. In maxillary hypoplasia, the treatment options are maxillary and advancement. So rate of relapse is very high in this. Scarring, muscular forces, adaptation, and instabilities there. So these are the this is the bimaxillary correction case of maxillary hypoplasia. Okay, and you can see a drastic change in the face of the patient. So biological bone deposition in response to the application of gradual tensile strength across the fracture and accompanied by stimulus histogenesis. So this is called as distraction. So distraction is regeneration plus active growth of the bone with ample of blood supply and mechanical loading. So this is an example of fracture healing versus distraction. So this is the impact. The fracture is there. Okay, and the fracture healing is there, deposition of the bone. So the soft callus is first formed, and then gradual remodeling is done in then the fracture heals like that. But when you remodel the bone and before the hard callus forms, you distract it, then the bone formation is more remodeled. So classification of distraction of is facial distraction. It is across the growth plates, and rapid palatal expansion is one of the part. It is also part of distraction, what we are using in orthodontics. So this is sclerosis distraction, which is across the fracture line. Okay, which is across the fracture line. In this, you can see this is sagittal split osteotomy, sagittal split osteotomy is done, and the distractors are there. They will slowly move the mandible apart. Okay, slowly move the mandible apart. So there are various type of external or internal distraction devices. In internal, subcutaneous or intraoral, submucosal, and extramucosal devices are there. So it may be tooth bone, bone bone, or hybrid, and maybe unidirectional, bidirectional, or multidirectional. So this is an example of extraoral this on the mandible of maxilla of the goat. You can see the expansion, how much we can do without hampering the pedicle of the blood supply and all. So external distractors are like forehead and all. Now these are not used. These were way back 20 years. This is rapid expansion devices are there. So slowly, but this is very cumbersome procedure. The patient has to wear this device every time. Nowadays, intraoral distractors, small distractors are there. So in this one, the advantages of external distractor, the osteotomy design is based on the aesthetics, good vector control. Second surgical procedure is eliminated and versatile and flexible. Limitations is dentition. Patient dentition can't be done with the external this distractor. Then patient tolerance, scar from fixation pins, and advent trauma. Now, internal distractors or intraoral distractors, these are the hidden distractors. These are the various distractors. Intraorally, they can be planted. Okay. Just like bone plating, you have to do this fixation, and then with the help of a small key, just taking the appliance apart. You can see this osteotomy here. This is the distractor. This osteotomy. One part is here and one part is here fixed. Okay. Then this is the key. When you rotate this key, this will go apart. So the key is like 1/4 turn. Okay. In the morning and 1/4 turn in the evening sometimes, and 1/4 turn in 24 hours sometimes. In maxilla, you can rotate it twice also, but in mandible, yes, 1/4 turn in 24 hours as far as I remember. In this case also, total maxilla. This is a level 3 osteotomy. Okay, level 3 osteotomy is done, and then total maxilla is taking forward. So various type of distractor. Mesh distractor is this. So internally this is placed, and this key is externally protruded towards the hairline. This scar will later on be hidden in the hairline. So in internal application, it is better patient compliance is there, and minimal risk is there. Limitations is multiple surgical approaches, secondary procedure, exit port for activation, and then limitation of vector control. And see, in this type of case, when the exit pole is there, there are chances of infection to the exit pole. Complications are intraoperative procedure oriented complications, then device associated complications, dislodgement, infection, vector, and consolidation. Post distraction relapse is the major complication, then malocclusion and growth retardation sometimes. These are the external appliances which we have used in our time. So these are the external distractors. So quite promising results sometimes you gain. But then the amount of pinhole, this infections and all, you have to deal with that also. This is a very common pick we have used in our books also. So you need a precise setup for this, and a precise OT setup for this. It's a major surgery, and maxillofacial surgeries, whenever it is a major surgery, so you have to get a backup of ICU also. So this is a complication case also. Speech therapy has an important part in this. Same case. Thank you. So this was a small topic as far as introduction to the distraction is concerned. Why we have covered this topic so that after this our orthognathic surgery introduction, cleft lip palate introduction, and distraction osteotomy. These small topics, they can be clubbed down. Okay, so basically these procedures, all the major surgical procedures, they need a hospital setup, and there is a vast science behind this. Each and every topic is capable of giving a postgraduate branch. Okay, in cleft lip palate, yes, plastic surgery and cleft lip palate is a separate thing. In orthopedic surgery, separate various lengthy and highly demanding this surgical courses are there, so they can't be learned in just like snap. But yes, introduction or basic idea should be there to how to refer a patient for orthopedic surgery. If the patient is coming for the aesthetics and all, and at a dental point of view, yes, we can establish a good component with the orthodontic treatment, but you have to look at the patient profile, that how much skeletal compensation can be done or not with the orthodontic treatment on here. Yes, if skeletal componation is required, then definitely you have to go for an orthodontic surgery. Okay.